We are now live. Hello, everybody.
Hi.
Surprise, Breanna's in Colorado. So we are here together and we've been working a ton today. But I know Shelby had put a post out there that we were going to go live to talk about childhood apraxia speech today. So I hope you'll join us for the next at least 30 minutes. We'll see how long it goes. So that those of you that join us, we'll just kind of introduce ourselves really quickly and then we're going to get started. So we are going to specifically talk about childhood apraxia speech today. So I'll go ahead and let Breanna introduce herself first.
So my name's Breanna Waldrup. I'm an SLP, obviously, and I've been specializing in apraxia of speech since 2012. I've been an SLP for more than 17 years. And Jennie and I met in 2018.
Yeah, probably
at boot
2018.
camp at the Apraxia Kids Intensive Training Institute.
Yeah, that was a really great training.
Yep.
It was awesome.
And I've done many other trainings, as is Jennie. And then I started providing trainings myself in 2016.
So awesome. Yeah, and I'm Jen Bjorem. I specialize in childhood apraxia of speech also. And I'm just really excited to be here today to kind of spread some word, to maybe answer some questions regarding childhood apraxia of speech. We put well, I'll go back really quick. So I've been practicing for over 25 years. And I've been working with kids with apraxia, like solely apraxia, for probably about 13 years. So I've been blessed enough to be able to have that opportunity within my private practice and then continuing on after I sold my private practice. So
I think we started that's what I did too, starting primarily in 2012, seeing just kids with apraxia or motor speech disorders. So we kind of started around the same time on that.
Yeah. Part. And when you see a lot of kids with childhood apraxia speech and you practice a lot, then you get good at it, right? And so I think with all the practice that we've had, which I'm always learning from other people, I'm always learning new things, but find that that you can move on your toes faster, you can kind of like turn on a dime quicker. I love being able to help these kiddos, and it's just such it's a disorder that I just love treating, and I know Breanna feels the same. So both of us currently still practice. I have 2 kids on my caseload that I see 5 days a week. So, if you see me post, videos recently, they're usually of Luke or of, Kingston. And so I see those 2 boys, consistently. And then how many kids are you seeing right now on and off?
So in person weekly, I'm seeing 4, and then I have some that come in for intensives throughout the year. And then I have a couple that I see only on telehealth because they live in another state.
Yeah, that happens too. So, well, I think what we are going to do today is that if you have any questions regarding childhood apraxia speech, you can go ahead and put them here in the comments and we will try to answer them. But we had sent out a newsletter earlier in the week and just asked people to ask us questions. And so, Breanna has those pulled up on her computer. So we'll just start there with some of those questions and then we can answer those as we go. And then anybody that has questions here, please throw them into the comment section and we will try to watch for those and answer those too. So, but we're just going to get started with the questions that were sent in through our newsletter this past week. So
the first one, which is a good one, is what is apraxia?
What is child apraxia of speech?
Yeah.
So childhood apraxia of speech is a motor planning disorder. But I think one thing to note, because I think people do or kind of assume that it is a medical diagnosis. It's not a medical diagnosis. So there's no medical tests that a child can be giving to determine if they have childhood apraxia of speech or not. When we consider it a speech sound disorder. So when we think about it as a speech sound disorder, we're looking for characteristics of childhood apraxia of speech and, the consistency of those characteristics rather than a test that's going to give us a medical diagnosis. And a lot of times childhood apraxia of speech is the symptom of other medical diagnoses, right?
Yes, for sure. So there could be a medical cause, and I always think about that with adults. Like we might have an adult who's had a traumatic brain injury or a stroke, and that's a medical diagnosis that's diagnosed by a physician with medical tests, imaging, blood tests, things like that. And then as a result of that, they might have apraxia of speech or another communication disorder, and that's diagnosed by an SLP. But for our kiddos, a lot of times it's idiopathic. So we don't know the medical reason. And then sometimes we do, sometimes that has been identified. So, and something else I would just add there with the features that you were talking about is that it's, difficulty with those parameters. So inefficiencies moving through space and time. And when we think about that, if we have a timing error, like with our vocal folds, then we could have a voicing error. Or if you have an error moving to the wrong, space, or your tongue is not the right amount of tightness, then you could have like a distortion or a vowel error, things like that. So those are the kind of errors that we're looking for when we're assessing for childhood apraxia of speech.
Yeah, we're looking for a good handful of errors, and we're looking for a consistency of those errors and patterns of those errors. So there's no medical test that can be given to a child. So to answer that question fully, childhood apraxia of speech is that disconnect in planning and programming for movements of speech. So which have that impact on intelligibility, have that impact on prosody we see, and have that impact on that co-articulation, which is basically a good description of childhood apraxia speech is a disorder of co-articulation or a disorder of movement. So hopefully that helps answer that question. We did see some questions come in through here, so I'm going to go back and read these. So child tells lots of words but forgets with time and never says it again. So does it mean that the child has the ability to tell those words or sounds again?
So hard to say. One thing that I really think about this is like the motor speech system is not very efficient for these kids who have not had treatment or very early in treatment. And so I kind of think about that sometimes like that right sequencing might happen. The system might be more efficient, so the word might come out clearly. And then at other times, maybe there are other factors going on. Their cognitive resources are being used elsewhere. A variety of reasons, and like maybe only like 50%, just throwing out a number, of the message comes through. So in that case, or the sequencing comes through. So in that case, you might have some of these errors, or sometimes maybe they're not really able to initiate and get any of that motor plan going, even though they're thinking it. So it's hard to, so yes, they probably can say them again, but there's a lot of factors that we can't see on the outside of what's going on with in their brain trying to sequence those sounds.
Yeah, that's a great answer to that question. Next question on here is assessment question. How do you perceptually distinguish between difficulty moving between articulatory configurations and segmentation? So, I think these can definitely go hand in hand. I know that they can kind of be under the umbrella of difficulty with transitional movements or also prosody, because prosody then is not that fluid flowing movement. Do you have an idea?
I agree that, and that's a great question, because I think a lot of times there can be segmentation. I think also sometimes when you're watching, I feel like you'll see awkwardness in the movement. Like the movement is not smooth, right? And it will be kind of awkward. But then we get into, okay, so is that actually some type of articulatory groping? But I've just sometimes too, I see like the jaw excursion, like being like over excursion or things like that. So it's just like the movement's just not real smooth, or it's just like the parameters are a little off, like, wow, we opened too wide for that vowel and things like that. So that's part of what I see with that difficulty with transition.
Yeah, and that difficulty moving between articulatory configurations. So a lot of times I'll think of that is just like what Breanna said, it's where it's like an awkward movement, or I like how Edith Strand says it, is wrong place, wrong time, is how she describes it. Whereas if you think about a child who segments, which many of our kids do segment, and again, that's a problem with co-articulation, but it's also a problem with prosody. And so like, especially if a child has a hard time, like, utilizing their vocal cords to lengthen and shorten, then it seems to like those kids become I don't know. A lot of times you'll feel like those kids are monotone and segmented. So they almost sound like a robot. So those kind of can go in hand as well. So I think it does fall both under both of those umbrellas of prosody and difficulty with initial or not initial articulatory configuration. It's just transitional movement gestures.
Yeah.
So, but it's a good question. I think that if you're seeing that, obviously it's something that we're going to need to work on. And it's not necessarily consistent across lots and lots of different speech sound disorders. So.
And I think the other thing you might sometimes see, we were talking about this earlier, is like, you might see like to say boo, we were talking about boo earlier, and you might see like ooh, or something like that. And again, then we were like, oh, is that initial articulatory, which in that case, it would be initial articulatory configuration, which is usually lumped with their transitionary movement gestures. So it's like, I don't know, it's just the movement's not smoothly co-articulated,
I mean, if we would
have, it's not quite a segment, and I can't, it's hard for me to replicate that.
But if like we would have recorded therapy with Luke today, we would have seen that so much. We would have seen that difficulty, that transitional movement gesture so much today in just the things we were trying to get in to see. But it's just like kind of being able to just recognize it. And I think it takes practice too. So it's a great question. I'm going to scroll down, see if there's any other questions. Here's one. Where do we start to teach communication for apraxia kids? Who is currently using hand-led? This child's currently using hand-led. And so where do we start?
I would start with a robust AAC system.
Yeah, I would too. I would definitely have some sort of, and also I would, yeah, exactly. That's what I mean. I would start with robust meaning that it's not simplified. It would be, assuming that the child has this ability to communicate.
Competence.
You're going to presume competence and give this child a AAC device that has a lot of options. So it's going to have lots and lots of options, and then we begin there.
Vocabulary, and start really building those language skills, giving them a way to communicate consistently because their speech is not consistent. So they can communicate consistently with a variety of communication partners.
Yeah, that's a great answer. I would totally agree. I'm scrolling through just to see. Hi, do you have any recommendations for treatment for young children with autism who also have apraxia? This is really great. I mean, young children as young as 2, 3, 4. I definitely think that what Breanna just said is making sure that we have a robust augmentative communication device for them. And then also, I don't know if you're specifically talking about apraxia, but I think like when we're specifically talking about apraxia, taking a motor planning approach for autistic children, children need to be able to imitate, or they also need to be able to have joint attention. So to do that types of things. Otherwise, as far as like for me, if I have very young children who might not be ready to do some sort of motor planning speech approach for like an apraxic child, definitely the AAC. And number 2, just in just modeling and in play and modeling and trying to work on that child imitating. What else do you have?
Yeah. So, I mean, where I start is connection and regulation with my autistic kiddos. So they need to be regulated. They need to be connected. So that's where we start. And then moving from there, and I'm always also thinking if they're a Gestalt language processor, thinking about natural language acquisition and how we're modeling, of course, AAC, coming into play. So it's like, first we have to be, connected and regulated. Then we can start building more language and communication. And then we can start including some principles of motor learning in still a very neuroaffirming way. So it's going to look different for a lot of, in my experience for my autistic kiddos, that's going to look quite different from the more neurotypical kids that I treat for apraxia. So we're going to start, again, following their interests, thinking of words that are super functional for them and getting, thinking about what NLA stage they're in, and making sure we're kind of picking appropriate targets that are going to make sense for that kiddo from their perspective, their language, and that are really functional and motivating to them. Which again is why it's so important to start with connection and regulation. And you do child led. And you build in the repetition through that, but you're not going to necessarily be doing like this big block of repetitions that we think of in apraxia therapy. It's going to be very in context, and you're going to be respecting the child's autonomy as you do that. So, I mean, we always want to respect any child's autonomy, of course. But for our autistic children that might be communicating in some different ways, sometimes we have to be a lot more in tune with them to know, to realize what they're communicating to us. So,
yeah, I mean, we did that with Luke today. It was a really great session with Luke today. It was, very child-led. When he wanted to pivot, we just pivoted with him. When he didn't want to be touched, he let us know, and we were like, okay, we're going to back off. Like we, touched his foot or something, and he was like, no.
Mm-hmm.
And,
we 100% respected that.
Yeah, we 100% respected that. So, he it is just a really, I think in every kid it's going to look a little different, but yeah, I love that I actually, when I made the answer, I skipped over that, but then you went back to it. So thank you for doing that. Yeah. That's important, Okay, let's see if we have any other questions. Thank you guys for all the questions. The child with CAS also having trouble with reading, although has phonemic awareness, but has difficulty blending and reading them. How can we work on that? So, this is a loaded question. Mm-hmm. Literacy and apraxia go hand in hand, and we've been kind of doing some background work here. Between Lauren and Breanna and Dr. Kelly Forcorson and I have been doing some background work here on trying to figure out how to teach kids with childhood apraxia of speech to read and have all those skills that they have. So it's been a learning process for me, for sure, because it's not my area of specialty. Breanna has more experience than me, and then Lauren has tons of experience in literacy, but not any experience in apraxia. So like bringing our minds together and trying to figure out and plan things for the kids that are on our caseload that also need to be working on literacy. I don't know if I have a place to start or have all the answers because it's so incredibly complicated. Maybe, I don't know if you have an idea better than me.
Yeah, I mean, it is a big topic for sure. So having those phonemic awareness skills is great. And then of course you want to work on the sound letter association, and using multisensory cueing. So definitely going to our structured literacy approaches, but then, modifying them. So our, structured literacy approaches usually do include multisensory cueing, and it's even more important for our kids with apraxia. So different things to think about. If you are working on these skills reading aloud, then just realize that you're not just working on reading, you're also working on motor planning for speech at the same time. So not being afraid to include some simultaneous speaking. That's such a powerful tool when we're teaching kids with apraxia how to talk. And it can also be really powerful when we're working on reading. So where we're reading together simultaneously at the same time. Sometimes even just that initiation of that first sound is helpful, and then we can fade that cueing. The other thing is to make the tasks to work on reading where they're silently reading and you're doing tasks receptively, so that you're not muddying the picture with speech. So yeah, it's a very complicated question.
It's a very complicated question. The other thing is, like Lauren always says, it's the most important thing we want from a child is their ability to comprehend. So where is their comprehension at when they're reading silently? Where is that skill set at? And then we have to go in and teach very explicitly, we should be teaching explicitly all kids how to read, but our kids with childhood apraxia speech, we're teaching explicitly, but we're also having to do a lot of adaptations. in order to make those kids successful. So we did some of this with Kingston today. So we have been working on words ending in ST. So like he was telling me, you're going to be last, you're going to be last, or you're going to be la. And I know he wants me to be last because he wants to be first. So then I was realizing he was having a hard time motor planning the ST. So then when I brought all the words out, and so I showed him that we have to do the snake sound and then the t. So I have a visual for the snake sound and the t. Then he was also flipping them around and doing the flat tire sound. So instead of cast, he would say cats. So then I would write the two words out. I would have the flat tire under cats, and then I would have the snake sound and then the dot under cast. And then what I did is I had the words written on the side so he could also see the words. And then I took pictures that represented those. So for the past 3 days, we've been working on the flexibility of him going between st and ts. So those two flexibilities, which is really hard, but it also has to do with literacy, right? And so then, so we've been incorporating literacy and speech together so that he's successfully reading those, but also successfully saying those.
Yeah. And I think in that case, then his literacy has progressed to such a point that actually seeing the letters was actually a visual cue for him.
Yeah.
And which wasn't the case not that long ago.
No, it was not.
So, which once you kind of make that transition, once, his sound letter association is, at a high enough level of mastery now where actually that was actually helping him that was helping to cue his speech. But you guys have done a ton of work to get to that point.
Yeah, we have. And we just released our Better Letters Educator Edition. So if you haven't seen that yet, we've been using that with Kingston, and it's just incredible. So it has the visual cue with the letter on the same card, and then we can put those together to combine words so that he's cued on the sound that that letter makes, and then we can scaffold that and bring that away and then take away the sound cues to just use the phonograms and just use the letters to help him read, so that, you know, he's also not only working on the motor plan, but he's also working on the reading aspect. And then we're teaching him the rules of reading as we do this too. So it's very, very complicated. We are working together as a team to create something that we can share with you so that you have some sort of guide how to teach children with severe speech sound disorders how to read, but it's in the works.
Yeah. And one other thing I would add, just when you are reading aloud with a child with apraxia, is I would really work on prolonging the sounds that you can instead of segmenting. So if we're reading cat, then I would be saying like cat, you know, and doing it together rather than like at.
Mm-hmm. So it's that successive blending, right?
Yeah.
It's like instead of segmenting, you would just blend them by stretching them all out. Yeah. That's a great recommendation. I'm going to go down to see if we have any more questions. Thank you all for all the questions. Oh, here's another one. I'm applying to grad school next year. Do you have any tips for me? Anything I should do now? Thank you. We have lots of tips for you, but we're going to skip this right now, Evelyn. I'm sorry, because we're going to just try to focus on childhood apraxia speech, but hit us up at Bjorem Speech and we'll send some ideas your way. All right. Next one. Any other questions? Thank you so much. Yes, it is difficult when it comes to doing motor planning exercises when the child has a hard time imitating and doing face-to-face activities.
So if we're talking about motor planning speech, then some other thoughts when a kiddo has a hard time doing face-to-face. And so I think about our autistic children who really struggle with that. So in one of my sessions this week, I was wearing sunglasses, and so that the child could visually reference my mouth without having any pressure to make eye contact. I also find that using screens can be helpful. So in that session, I had my iPad and we were,
just like we are now. Yeah. Like you get side by side with the child and they really enjoy this. So iPads work really well. I will sometimes use my phone, but it's kind of small.
Yeah. And then also, of course, we want them to have the visual cue from our mouth, but also if looking at someone's face dysregulates them, then it's probably not that helpful. Like you kind of have to weigh, for each child in each moment. So I've also had kiddos that we were side by side and they would use their peripheral vision to check out what I was doing with my mouth. So it doesn't have to be, and it doesn't have to be that face to face. Again, regulation is the most important thing. If the child's dysregulated, then we're not going to get anywhere. So that's the thing that I would really focus on. And I mean, progress is going to be a different rate of progress, but progress can still be made.
Progress can still be made. And as the child grows, they learn that, oh my gosh, this is helping me. I can work through this and potentially do this,
Yeah. And I've seen that progression with some of my kiddos, over even years where we started just, being side by side. And then eventually could be like, I would have to wear sunglasses, but we could be face to face. But then it depends on the day, and it's, again, most important to just, watch their cues, teach them self-advocacy, to let which also like Luke did today, working on self-advocacy and supporting that and respecting, their autonomy. And so, different days will be different. Some days we might get more face-to-face and some days we might not. And that's okay.
Yeah. One other thing that I've done with some of my kiddos is just record myself doing the motor plan and even giving it to their parents. And then the child may just want to watch it over and over again.
I've done that when I record both of us and then they love watching themselves.
Yeah. So, what I do a lot with Kingston is I'll just pop on Zoom. And we'll just pop on Zoom and I'll record us on Zoom or, and so that then I can either use that to share it with his parents, share it with his teachers, share it with a colleague so that they can tell me, you know what, you could have done this better or changed this or done this. So, a lot of growth for me as well. So I think all of those ideas are really good. And for groping or jaw excursions, when the child is used to grope while speaking, how do we work on that if there's no symmetry between the lips or the jaw? So, and for groping or jaw excursions, when the child used to grope, how do we work on that? So as far as I just go back to simultaneous production and I'll give all kinds of cues. So I feel like when a child will do the movements with me, they're going to be way more successful. And so if something's too wide or something's too small, then we'll talk about that. So we'll use tons of cues. So placement cues, we'll use
tactile cues.
Yeah, tactile cues if needed. Absolutely. Any type of cues are all for the child to understand where they're at in space and time and what that movement looks like.
Yeah. And so I guess I don't usually think about it as that, I'm working on groping. I'm working on improving the efficiency of the motor planning and programming. And then as the efficiency of their system improves, then the groping decreases. I mean, as many of the characteristics do. So I guess I never really think about I don't see groping and be like, ooh, I need to fix that. I'm like, oh, let's keep working to make our motor planning more efficient. So increasing cueing. And there also sometimes there's trial and error and that's okay. If the child is doing some trial and error movements to figure out and they figure it out, then that's a huge win. So, I'm in that case, the groping is a positive thing because they knew they didn't have it right and they were finding the right spot. So I'll say, great job. I saw you trying so hard that you got there, you moved the right way. But also I'm ready to jump in and provide some extra cueing to help them.
Yeah. Great. Let's see. Do you have Apraxia of speech materials and materials for visual supports to accompany CAS? So we don't have right now Breanna and I are in the process of creating, a good handful of childhood apraxia speech resources that we ourselves feel like we need in our practice. And so if we feel like we need them, we feel like other people are going to need them. So we're in the process of publishing those. So we're hopeful that those will be out in the next year. But as far as like supports for childhood apraxia speech, I use, all kinds of cueing, any type of cueing that I can fathom up, and it may look different from each child. So whether it be tactile touch cues, or whether it be, visual cues or placement cues, I use all of those. But I do tend to use the Bjorem speech sound cues. So my cues that I created lately with my older kids, I've been using, or like Kingston, because he's a bit older and we're working on literacy, I've been using the better letters, because those have the sound cues that he knows, and now the letters, and it's got spelling rules and spelling patterns in there that are going to help him know and understand, why we do what we do in English. So I've been using those. I've also used a lot of our minimal pairs decks, because kids with childhood apraxia speech also have phonological errors. Or phonological patterns. And so they have those patterns that we need to work on. Those childhood apraxia speech and phonological patterns go hand in hand. So as long as, you're working on phonological patterns with that underlying support of, a childhood apraxia speech approach and principles of motor learning, then you're going to make progress. So if those kids have, S cluster, reduction, or if they have final consonant deletion, or if they have stopping, or if they have gliding, those are all things you can do through approaches like minimal pairs approach or through cycles approach. So yes, you can use those for kids with childhood apraxia speech. The other material that I do use a lot is our box of sounds. And it's not necessarily to go and pick the S sound or the D sound or the T sound to work with a child, but like, we have so much art in those decks that I can go, and if we're working on puppy, I can probably go pull 20 puppies. And so then I've got lots of different puppies in my hand from all the different decks, so that we can hide the puppies around the room and work on the word puppy over and over again through play. Any other ideas that you have?
No, I think as far as like materials, the sound cues are really helpful for some kids, and then other visual supports. I use a lot of gestural cues, which are
the prosody cues.
Visual.
Do you use those at all lately?
Oh, yes.
Oh,
well,
our
that's a great
prosody
one.
cues.
Yes.
Yeah, I
the
forgot about
prosody
that.
deck. Yes. I use the prosody deck all the time. I can't believe I didn't think of that immediately.
That's okay. I didn't think of it either. I was just
That's
like,
true.
wait a minute.
Yes.
What deck do you have?
Yes, I do use the prosody deck all
That's
the time.
the pink deck. So the prosody deck. The nice thing about the prosody deck is that on the front side of the cards, it's for younger kids. So there's illustrations and it's kind of whimsical and fun. But on the back side of the cards, it's more for more grown-up kids, where you can see numbers and words and less like art or like kiddie type feeling. Whereas then you can use them with older kids so that they feel that it's not babyish or young kiddish. So that's another one. Oh, Rebecca Reinking just created the S cluster elicitation. So those kids with S cluster errors, this works magical, because you take that snake sound and you match it up with a word, which creates another word. Like if you do S and a guy, then it's going to go sky. And then you get the picture of a sky. So this has helped, like Kingston and I've worked on those. I know Hunter and I worked on S clusters at one point, to just remediate that, S cluster reduction. Even though they're both apraxic, they still needed to work on that. And once you get those S clusters, their intelligibility increases significantly. So that's another good deck. This one right here is coming out soon. This is the tail sounds. Rebecca Reinking also made this. So this is great for final consonant deletion. So those kids that are deleting the end sound. So this isn't out yet. This is the only deck I have, but when this comes out, it's a puzzle. So you can see here that the goat, head and then the goat tail. So when they delete the final sound or the tail sound, then the goat isn't complete. Then he doesn't have a backside. So this is really helpful for young kids in those visuals again. And this is also helpful for kids with childhood apraxia speech. So, she meant visual supports to accompany sounds like flat tire or snake for all of the sound cues. So wait, any specific material to diagnose, so visual supports to accompany. I mean, the Bjorem speech sound cues are all of these. So if you're asking about speech sound cues, catching KY. If you're asking about, those would be the Bjorem speech sound cues.
Mm-hmm.
So I don't have them down here with me.
Yeah,
but it's the brand new second edition deck. They come in a big size and a small size, and that's what I use every day, all day.
Mm-hmm. And that has all of the phonemes. So there's a visual for every phoneme.
Yeah, that's right. And so it's excellent.
And even one for intrusive schwa now.
There is one for intrusive schwa now. And we also
we can toss out.
Yeah, that's right. We also have the Lori Berkner Better Letters deck, and that has all the sound cues in it too with the letters, and all the songs on YouTube go along with that. So we have all the letters in the alphabet, and then even digraphs. And so that would be a good place to start too if kids are musically inclined and they like to listen to music. Today we used it with Luke because he loves it. And then you just go on YouTube and you slow the rate down of the song. So on YouTube, you can go into settings and slow the rate down to like 0.75%. So it slows the song way down so that the children with apraxia can follow along better, more motorically. And then if you need to pause in between to find the sounds and practice the sounds, you can do that as well. Any specific material to diagnose CAS and at what age range? So, the DEMS is the dynamic motor, go ahead. Dynamic evaluation of motor speech skills.
There you go. Yeah.
In unison, simultaneously.
And that starts at age 3. But for the DEMS, which is a great dynamic assessment, but it only goes up to 3 syllables. So if you have a child who is older or as their level of breakdown is at 3 syllables or above, then you'll need to use some more informal tools. But yeah, DIMS is great if you have kiddos who are breaking down at 3 syllables or less. And then
the ProCAD. So the ProCAD is an open access. It's research done by Jennie and Kristen Allison and Ruth Steckel. And so it's open access. So you can go out and grab the ProCAD. You have to,
which is to guide your clinical thinking so it's not a complete assessment, but it's to guide your clinical thinking, as you do your different speech tasks.
It also gives you
not validated yet, but they're working
not yet. They're working on it because we got to talk to them, but they are, but it does give you nice differentiation between dysarthria and childhood apraxia speech, which hasn't really been done before. So I think that's pretty nice, is that you can go and kind of educate yourself on that. And then I have an assessment, that Breanna and I have been, I've been selling my assessment for several years, but Breanna's kind of jumped on board with me to help me like us together, bring our brains together to kind of update this informal. I don't want to call it an assessment. But we can use it informally to diagnose kids with childhood apraxia speech. I like to call it an inventory. So it walks you through, I think we go all the way up to 5 syllables. And then we also have a story retell that we have. It's the new one, when we get it for print, it's beautifully illustrated by Aishwarya. And then we've got some other ideas in there too to help guide you. And then I'm sure we'll be doing some courses on that once that's out and ready to roll.
So because when we're diagnosing apraxia, we want to assess for those features across multiple speech tasks. So our idea with this tool is to help you have those different speech tasks all in one tool. Whereas right now in a lot of my evaluations, I'm like, okay, I'm pulling here to do this speech task and pulling from here to do this speech task and pulling from here to do this speech task. And then evaluating that using the Mayo 10 or the guided by the ProCAD. So we're trying to kind of pull some of those tasks all together into one place, into one tool.
Yeah. So we're working on that. And so that's kind of behind the scenes, which let me see if we have any other questions. Just saying hi and enjoying this. Hi, Vanessa. I love that. What is the minimum number of sessions you recommend in a week for a child with CAS? That is a loaded question.
Yep.
So research states for children with childhood apraxia speech, shorter sessions, more frequent. So let's say a child were to get 2 30-minute sessions a week at school. I would love to see that child get 4 15-minute sessions if possible. So shorter sessions more frequently.
Yeah. And I mean, there's more research that's happening on this right now. And so we'll see what that says. I also am always just like, it's very dependent on the child. Because I will also say, so sometimes, those short sessions are great because you can jump in, they're focused, and you can get a lot of repetitions quickly. But I've had some other kids that, that's not how they operate. And so, we kind of need longer sessions. And so to kind of get in and get them going. So I think it just depends. I also find that it really, really depends on what other challenges the child might have and what other therapies they're doing, because there is such a thing as too much therapy in my experience. And so if I have a kiddo who's also doing OT and also doing PT and, it's a lot, and they go to school, and I've just seen, I think you just have to do trial and error. So yes, we have the information from the research, and also, a lot of that research too is, that's where they're doing more like intensive sessions, and then there's breaks and things like that. So you have to think about that as well. So it's really what works for that child, and also what stage of therapy they're in and what family carryover looks like.
And
that's why it's a loaded question.
How much the families can tolerate. Like, me as a mom having, 3 kids, can I really get my kid there 5 days a week? I'll do my very best. So, I never judge a family. I would, I'm happy to recommend, as long as, they can do what they can. And, I'm happy to help in any way that we can. Breanna and I also had really great success with high intensives, like a week-long intensive where you see a child, like sometimes I'll see them 2 to 3 hours a day. Yep. For like 5 days or 6 days, or I might see them over a 2-week period, 2 to 3 hours a day. I have to go take a nap every day after that happens because I'm exhausted. So I know the child's exhausted, because it's very intensive, but I've seen huge gains in the kids that I've done intensives with. So I think, I don't know how much research there is on intensives, but at least the intensives I've done, just really, really, really great results.
Yeah. And I think, we have the rest studies, where they did more intensive. So 4 times a week for 3 weeks, but then followed by a break.
Yeah.
And so, which they also did that with the Nuffield approach in the RCT. So there is some support for it. And then clinically, I think, those of us who have been doing it, I've seen a lot. An important thing to keep in mind is if you do that intensive, the child does get a break, a consolidation break afterwards, to really integrate everything that you just did in that intensive.
Yeah, I agree. I think that's important. Like right now, the 2 boys I see on my caseload, I see 5 days a week for 30 minutes each, but I travel a lot. I travel the world presenting and teaching on childhood apraxia speech. So, we do take these breaks. And then this Friday will be our last day until August. So they take the summer off. I take the summer off. And so that gives them time to focus on other things, do things with their family, be a kid, do all the things. And then we hit it hard again in the fall. So I think, like Breanna said, it definitely depends on each individual child.
And I've had kiddos make very nice progress with great family carryover at once a week. And then I've had kids make great progress at 3 or 4 times a week. So yeah, it just depends.
So yeah. How to counsel a parent about apraxia and what home program to be given to start up as parents wouldn't know prompt or motor-based approaches. Yeah, this is also a loaded question. We're having a discussion about this before we came on, because it is really hard, because we, as the speech therapists, have to educate our families on all the things that go into childhood apraxia speech therapy. And here, like Breanna and I do this only apraxia, and we do it every day, and we've done it every day for 18 years, 15 years, something like that. And then we expect parents just to jump in and know how to do this. It's not easy, and there's so much to it. We also are expecting speech therapists that are in schools that may have one child in the whole school to dig in and know how to do this. And it takes practice, and it's not easy and it's hard. But I try to keep my parents in therapy as much as I possibly can, or I'll record therapy sessions, or I'll send videos home about what we're doing, why we're doing it. So I'm constantly educating my families on all the things that we're doing and what and why. And I also keep my target list small. So I'm not working on, 75 S words, or I'm not going through, 25 K words. I'm keeping my targets small so that the families can, with lots of repetition and practice, begin to see and understand how I'm teaching these motor plans to kids. So it lays a lot on the speech therapist to educate their families.
Yeah. And like one thing, I also have parents in on my sessions, or caregivers, nannies, whoever wants to be there. And so they can, grandparents, absolutely, see and hear what we're doing. But I teach, family members to do simultaneous speaking, because I'm like, whatever the child is trying to say, if we do it simultaneously with them, we can help them. And maybe that's just a word that comes up and they're at the zoo and they really want to say it. And maybe that's not a word that we're going to really target in therapy, but in that moment, the parent can help them say that. Why not? What's the harm in that?
There's no harm in that. Yeah,
so if I teach a family one strategy, it's simultaneous speaking and how to do that. And like, okay, let's say it together, let my mouth help your mouth to move. And, so that's one and then same thing though, I like for actual like specific target lists, I will, I wait till we get to a certain amount of success, and I've started to fade cueing before I send those home with families. And I'll tell them that I'm doing like multiple different cues. This is really hard work. This kiddo needs to know that they're doing this hard work with me, and then they get to go home and you get to be mom and dad. So there's also that we want to be really respectful of that relationship. And for the kiddo too, that they know that they have to work really hard for a period of time. They don't have to work hard all day long. But once words are up to like minimal cueing, then I'll start sending those home where I'll say, okay, now that they can self-correct, or they can quickly correct when you say it back to them or something like that, then that's when I'll tell parents, okay, now run with it at home, but not when it's super new and hard and we're not having, our success is, not where we want it to be yet.
Yeah. I usually tell my parents, like, even Kingston today, like, I think he backed something and I go, what was that? And he just fixed it. Yeah. So like, I know that he can fix it with hey, I didn't catch that. Or like there was a communication breakdown or recast communication breakdown. And so then I'll tell his parents of like, well, if he's doing that, you can cue him to do that and then he'll fix it. So he doesn't need tons and tons of support to fix that. Yeah. But when there is a lot more heavier support, like Breanna said, I try to keep that on my plate until I feel comfortable that the parents feel comfortable that they can do that. So yeah, I mean, it was a really, really great question. Anybody else have any questions in here? I'm rolling down. Oh, a child with Down syndrome, 3 years, 10 months, express the needs or reaches out to objects and imitates mostly using single syllable or two syllable. I do suspect difficulty with planning and coordination. Is it early? If you're asking if it's too early to suspect difficulty with motor planning, it's not too early. Is that what you're getting from that?
Yeah.
I would definitely talk to a speech therapist or consult with a speech language pathologist that has experience in the area of childhood apraxia speach. And
I would say motor speech, because you also want to look at dysarthria.
Oh, dysarthria as well. Yeah, that's good. Good call. Yeah.
But the child may not have enough speech to differentiate yet. So in those cases, when the child doesn't have enough speech for us to assess for characteristics across multiple speech tasks, but we're seeing some indications, then we can go ahead and start therapy based on the principles of motor learning and using multisensory cueing. And then as the child develops more speech, we can come to a conclusive diagnosis over time. But there's no harm in, as long as, again, we're staying neuroaffirming and everything, in starting to implement therapy based on the principles of motor learning and using multisensory cueing.
Yeah. And here's another question, another assessment question. The younger ones, what if you can't get 3 speech tests, but see some discriminative features? Then you go ahead and do that response to treatment. You take that motor planning approach. You use principles of motor learning. You do all those things. And then as that child progresses, then you'll be able to make that differential diagnosis. So I always err on the side of caution and go ahead and take that approach, because if the child has apraxia, they're going to make progress. If the child doesn't have apraxia, they're going to make progress. So
you can use a working diagnosis, and I'll even sometimes have goals of being able to, like, I've had kiddos that couldn't engage in a thorough dynamic motor speech exam. Like maybe they could do a little bit, but not like the full thing, or, so I'll even have goals with some of that they'll be able to complete a dynamic motor speech exam or a more extensive one. And that's not, because a lot of the things we're doing in therapy, like learning how to do simultaneous speaking and becoming more comfortable with cueing and things like that, are things that we use in a dynamic motor speech exam. So as their speech progresses, then we can obtain more data and come to then a conclusive diagnosis. But we can use a working diagnosis like suspected CAS for a time.
Yeah, great questions. To suspect apraxia speech or give more time. Oh, I would not give more time. I'm not one to give more time. I'm one to jump in, and if there's a concern, or if there's, a speech concern, especially, if your child has other diagnoses or has comorbidities, then I would hands down, start in and start working on things now. So even if you can't yet diagnose childhood apraxia speech, like we were saying, go ahead and move through that therapy when that child's ready, or at the stage they're ready at, as far as you're using that neuroaffirming approach. So yeah, great questions. Being in the sessions is a huge benefit. Wouldn't know about the schwa if I hadn't sit through all the schwa sessions. Thanks, Lori Beth. That's amazing. She does know a lot about the schwa. And there were some times where she, like Lori Beth, was like, that's the schwa. And then we created a new term called schwaing. So it's the actually verb of the schwa. It's the actual
and then
act
schwa?
Of intrusive schwaing. So it's called schwaing. That's so funny. I love that so much. Wow, we've had lots of people. Whoa, I'm loving this session. It's amazing that you are answering all of our questions. Thank you. We're trying. We didn't expect to have so many questions. An 8-year-old with higher receptive than expressive language, few consonants, and practically nonverbal, only uses AAC to communicate minimally, requesting, not stimulable for any motor planning. Yeah, I mean, I would just definitely say AAC. And then, if working on expanding any type of sounds at all, any types of sounds.
Yeah. And I go back to that, regulation and connection, and knowing what the child really wants to communicate, and then building language and continuing to use AAC to build language. So, because I'm really concerned that we're using AAC minimally for requesting. So I want all those communicative functions. And it is, unfortunately, a kind of a fairly common pitfall that AAC ends up being used just for requesting. So we want all those communicative functions, which is also like how robust is the system? So I go back to those, like, more, to me, core things: connection, regulation, and language, that has to come before motor speech.
Yeah. And yeah, I would agree. I like that a lot. That's hard. Let's see. I think that's it. I think we answered everybody's questions. Okay. We're hungry. We're out. We're going to dinner. Thank you all for joining us. And yeah, this was fun.
Yeah. Follow both of us.
Follow Breanna.
Waldrup.slp.
Yeah. And then Bjorem speech too. So we'll definitely get this out. I think we're going to put this on YouTube, and I think we're going to put this into a blog, and we'll have it for everybody to rewatch. So thanks for joining us.
Night.
Bye, everybody.